When we think about managing osteoporosis, our minds usually jump straight to bone density. But what if I told you that's only part of the story? Today we're going to step into the clinic and get the perspective of Assistant Professor Dr. Farhad Mustafa Musa Atrushi. We'll break down his key insights on a much more dynamic measure, bone turnover markers, and see how they are completely changing our view of fracture risk. Okay, let's dive right in.
For years, the Bone Mineral Density Scan, or BMD, has really been the gold standard. But is it telling us everything we need to know? I mean, it gives us a static snapshot of our bone mass, right? But what if the real story is in how active our bones are, moment to moment?
So here's our game plan for this explainer. First, we're going to look at why BMD alone has its limits. Then, we'll uncover the telltale signs of something called bone turnover. After that, we'll see how doctors are putting these markers to work. And finally, we'll put it all together for a much clearer picture of who's really at risk.
All right, let's start with what we all know. BMD is the criterion standard, no question about it. But bone fragility, well, it's way more complex than just density. And a simple snapshot, as you're about to see, just isn't enough to predict who's truly in danger of a fracture.
Now get this. This is the slide that really makes you stop and think. 50% of patients who actually break a hip have bone density scores that are not technically in the osteoporosis range. That right there tells you, loud and clear, that we are missing a huge piece of the puzzle.
And this really gets to the heart of it. Think about it like this. A BMD scan is like a single photograph of a building. It tells you how much brick and mortar is there at one specific moment. Bone turnover, though, is like having a live video feed from the construction site. You can see the demolition crew tearing things down and the construction crew building things back up. It's all about the activity, not just the static mass.
So let's go ahead and visit that construction site. Your skeleton is constantly remodeling itself, 24/7. And the evidence of all that work, those telltale signs of turnover, well, we can actually measure them in your blood and urine. These are what we call bone turnover markers, or BTMs for short.
To put it simply, BTMs are basically the biochemical dust that gets kicked up by your skeleton's construction and demolition crews. When new bone is being built, that's called formation, certain proteins are released. And when old bone is being broken down, that's resorption, different little molecular fragments are let go. And the amazing part is, we can measure all of this.
So it really breaks down into two teams. You've got your formation markers, which tell us how busy the builders, the osteoblasts, are, and then you have the resorption markers, which give us a direct window into the demolition crew, the osteoclasts. By measuring both, we get a real sense of the overall pace of the job site.
On the building side of things, some of the key players we look for are things like bone-specific alkaline phosphatase, osteocalcin, and a really sensitive marker called P1NP. P1NP is basically a little piece of pro-collagen that gets snipped off as the new bone matrix is put down.
And then for the demolition crew, the most useful markers are little fragments from the breakdown of type 1 collagen, which is the main protein in our bones. So clinically, we're often measuring things called CTX and NTX, which are the end pieces of collagen, and another one called DPD.
This slide gives us a really cool look at one of those resorption markers, DPD. On the left, you see its chemical structure, but on the right is where it gets interesting. You can see how these DPD molecules act like little rivets, linking the collagen fibers together to give bone its strength. So when bone gets broken down, these unique rivets get released, and we can measure them.
Okay, so that's the science. But how do we actually use this information? Well, bone turnover markers have three really powerful jobs in the clinic. They help us predict future bone loss, they let us better assess fracture risk, and they help us monitor if a treatment is actually working.
First up, prediction. This chart shows it so clearly. The higher your levels of markers like DPD and osteocalcin are to start with, the greater the chance you're going to lose bone mass rapidly over the next few years. These markers can actually identify who the fast losers are, even if their BMD still looks pretty good.
Next up, assessing risk. And this is where it gets incredibly powerful. Take a look at this data. If a woman has low BMD alone, her 5-year fracture probability is about 39%. If she has high bone turnover alone, measured by the marker CTX, her risk is about 25%. But the real magic happens when you look at them together.
And there it is, 54%. For a woman who has both low bone density and high bone turnover, the 5-year fracture probability jumps to a staggering 54%. You see?
By combining that static picture with the dynamic one, we find a much, much higher risk group that we might have completely underestimated otherwise.
And finally, monitoring. A huge challenge with osteoporosis treatment is that you might have to wait 2 whole years for a follow-up scan to see if anything's changing. It's easy for patients to lose motivation. But BTMs, they change fast, giving that early feedback that can, as this quote says, really help people stick with their therapy.
And the process couldn't be simpler. We just measure a resorption marker, like CTX or NTX, before a patient starts therapy. Then, we check it again just 3 to 6 months later. We're not waiting 2 years for an answer, we're getting one in a fraction of the time.
And we even know what good looks like. We have clear targets. A drop of more than 30% in serum CTX or over 50% in urinary NTX tells us 2 things. 1, the patient is taking their medicine, and 2, the drug is doing its job. It's a quick, clear confirmation that we're on the right track.
So what does this all mean for the future? Well, we're moving away from relying on a single data point. We're heading toward a more complete, more dynamic understanding of bone health and what really puts someone at risk for a fracture.
And let's be absolutely crystal clear on this key takeaway. Bone turnover markers are not here to replace BMD scans. They're here to complement them. When you use these 2 tools together, you get a much richer, more accurate, and frankly more actionable picture of a person's skeletal health.
Ultimately, preventing fractures means we need a global approach. The future of risk assessment is going to integrate bone density, the rate of bone turnover, and all these other critical factors. Things like bone architecture, muscle function, and even a patient's risk of falling. Bone turnover markers are a vital piece of this much bigger, more comprehensive puzzle.
And all of this leaves us with a really fascinating question to think about for the future. As these tools get even better and more accessible, how is having this kind of real-time metabolic data going to completely change the way we manage bone health for every single person on an individual level?
The clinical data and many of the insights for this deep dive were drawn from an excellent review on Medscape.
And, of course, for the clinical framework that we walked through today, a very special thanks goes to Assistant Professor Dr. Farhad Mustafa Musa Atrushi. His work was really the foundation for this look into the modern management of bone health. Thanks so much for watching.